Here we are going to demonstrate a left sacroiliac joint fusion surgery utilizing two implants. We're getting our starting point and our patient in the prone position. The initial circle is over the posterior superior iliac spine, and there's a line drawn up the mid-axis of the femur. We draw lines connecting those 2 points, and that is a very typical safe starting point for this surgery. We're lining up our outlet view here, which is going to be for cranial and caudal correction. We're starting off with our 1.5 millimeter K-wire that we use simply to get our starting point so as not to injure any of the surrounding structures. Once we have this pin in the general vicinity of the safe starting point, we check the inlet view, which allows us to do corrections in the anterior and posterior planes. On this view, we make all of our corrections in the beam of the outlet view so as to only do a uniplanar correction. Utilizing the small pin allows us to fine-tune the starting point and make sure that when we shift it around, we don't injure any of the neighboring anatomic structures. We are to posterior and aiming to anterior with this starting point, so you can see the correction on the bottom left image, and our new starting point is in a much better alignment. It just needs to aim slightly posterior. Now we went back to the outlet view and are fine-tuning our safe position with our starting pin. Again, corrections are made in the inlet view on this view to avoid biplanar correction. Here you can see we move slightly cranial. Now that we're happy with our starting point, we make a small 2 to 3 centimeter incision directly anterior to the initial starting pin. Then I take a 3.2 millimeter guide pin and place this directly in alignment with the initial K-wire in a concept that I call kiss the tips, so that we get exactly where the other pin was. This one is for very subtle fine-tuning of the starting point. We're going slightly cranial so that we go right above the S1 foramen in the middle of what I call the safe zone in the upper sacral segment. The alignment has been maintained on the inlet view, and we have a safe trajectory planned. I mallet in the pin to the periosteum, and then on oscillate, I place the guide pin into the ilium and into the SI joint and into the sacral ala, and ultimately into the vertebral body of the corresponding sacral segment where the best bone is in the sacrum and allows us to accomplish the goals of our surgery safely and effectively. We go down to the SI joint and I check sequential intraoperative imaging to ensure that the pin is proceeding in a safe zone. You'll see how I shifted my drill in line with the previous image as a mental crutch into which way we move our pins to ensure, again, that we do only uniplanar corrections. See that I'm aiming a little bit too anterior, so I'm milling it posteriorly to get a much safer trajectory to stay behind the anterior portion of the sacral ala. We embedded the pin down to the sacral S1 neural tunnel, and then we took a lateral view, again, to make sure that we have a good lateral view and that we are behind the iliac cortical densities in the body of S1 and primarily not anterior. This was a safe pin placement. And then we complete our trajectory into the mid portion of the corresponding sacral segment vertebral body on oscillate to avoid binding up any tissues. The incision is then made about 5 to 6 centimeters to accommodate the eventual guides. We take the 11 blade on a long handle and slide directly down the axis of the pin without doing any other incisions directly down to the lateral wall of the ilium. I'll then give myself some counter force, and I use my finger to help bluntly dissect through the gluteus maximus, medius, and a portion of the minimus to ensure that we don't entrap any vital structures. These dilators then are placed directly down onto bone. And then we take our working portal, which has some teeth on it which embed into the ilium, and they go down to the ilial wall and then we do gentle impaction to impact the teeth into the ilium. You can hear a nice pitch change when the teeth have fully seated. When we take this out, we would ideally like our pin to be in the center, so I fine-tune the guide to ensure that our guide pin is in the center of the cannula. Then I place 2 stabilization pins directly opposite from each other into the ilium to help stabilize the working portal to avoid it losing position during the case. This essentially finishes the most critical step of the case, which is ensuring safe placement of the guide pin that won't move for the remainder of the case. We then measure the implant and ensure that there is a good corresponding measurement from our preoperative templating. Once this is done, we put our working inner sleeve in, and this is what will allow us to set the depth. This is the second critical step where we want to accurately identify the depth of the SI joint from the lateral ilium. This first drill is the pre-drill for any type of cannulated screw implant. We place this to the SI joint. I usually save an image, then go across the SI joint to make sure I'm able to accurately feel the SI joint, and then swallow up the rest of the pin. This does have some bone graft on it that can be utilized as part of the bone grafting procedure in a few minutes. We place the other remaining guide pin in place as the first guide pin is usually stuck into the initial drill. This drill tip goes directly down to the SI joint and across the SI joint and is the second critical step to set the depth of the SI joint. So you can see I take a shot here and I am on the ilial side of the SI joint, and then we check another image to make sure we go across the SI joint. The laser line on the drill allows us to back up the guide to help set up the depth of the SI joint and also ensure that we don't plunge unnecessarily into the ala in an uncontrolled manner. We do grab some bone from the sacral ala, and we do want to put this in slightly to allow us to accomplish that. If you can't visualize the SI joint well on this view, you can also do a 10 to 15 degree roll back view to look down the SI joint. This is largely done on tactile feedback. The bone graft is maintained in the drill that I just took out. This is the decorticating tool and is what aggressively decorticates the SI joint. The word blade is written on the handle and should be placed perpendicular to your outlet beam so that you can see the cutout. The cutout on the end of the decorticator corresponds with the maximal diameter of your decorticating tool. The outer diameter is right around 38 to 40 millimeters. And on preoperative templating, you can adjust how far you would like to decorticate based upon the distance between the cranial SI joint and anterior SI joint, which are typically your limiting structures. You always have unlimited decortication potential caudally and posteriorly. Every few turns, I obtain an image to ensure that we are going cranial and caudal appropriately and that we like the depth of our decortication. At times where there is any confusion, or if you're not sure if you are in the SI joint, you can advance the distance of the working portal with a few turns in or a few turns out to help increase the depth of your decortication. I do this most of the time. You can see here what the aggressive decorticator tool is doing and the path that it's taking out. This is removing the arthritic SI joint cortical bone and getting bleeding cancellous bone to bleeding cancellous bone to optimize the fusion conditions. Here, I'm doing just that. I'm going in a few extra millimeters to decorticate more medially and ensure complete decortication of the sacral side of the SI joint. You want to ensure that you can get free rotation in both clockwise and counterclockwise directions. I always obtain images both cranial and caudal to have a better picture of the decortication zone. Now we will repeat this. Instead of going 3 more millimeters medial, we go 3 more millimeters from the starting point laterally to help ensure appropriate decortication of the ilial side of the SI joint. Once the decortication step has been completed, we copiously irrigate out the SI joint with 2 or 3 bulb syringes. Careful, slow suction helps prevent clogging, but inevitably the suction device will clog, and a 3.2 millimeter guide pin can be used to unclog the suction device. I found it very helpful to pinch the end of the suction tubing at this point and use irrigation through the suction tube to help irrigate from the inside of the SI joint out. Here's typically how we unplug the suction device when it is full of intra-articular debris. The fluid from the irrigation tube will eventually come out much clearer, indicating that you have appropriately irrigated out the joint of the intra-articular debris and cartilage fragments from the SI joint. Once we have completed the irrigation step, I take an image to ensure that I see a nice lucent zone in the SI joint from the suction and decortication. The next step is bone grafting, and you would like to place the depth control to the deepest point of decortication to ensure you are bone grafting from medial to lateral. When the bone grafting device goes in, I like to have it flush with the C-arm so that it shows this orientation, and then slow, steady plunging of the bone graft material goes into the zone, and you can see oftentimes an opaqueness from the bone graft material spreading out through the decortication zone. Once this is done, I usually take what I call the centralizer at this point, and then place the 3.2 millimeter guide pin back in place. This should be freely floating back into its initial position as long as your guide pin has not changed. If there's any confusion on this, the safest thing to do is what we're doing here, and quick check your inlet view to make sure the pin is in the same place. This will help avoid any complications of the pin obtaining a new trajectory. And you can see it's in the same trajectory as we initially had in the middle of the upper sacral segment. We're getting ready to place our final implant. We take out the stabilization pins on power. We took out the working portal. And now we have our final implant with bone graft placed into the fenestrations and any remaining bone graft placed into the threads proximally. We place this in under power, only about 75 to 80% of the way in. Then we take out the inner working portal. I place my finger into the wound at this point to clear out any gluteal fascia from underneath the washer of the primary implant. Then, under direct palpation, I seat the implant up against the lateral wall of the ilium to maximize our compression potential. This view allows us to avoid stripping the implant in osteoporotic bone. It also allows us to visualize compression of the SI joint, which is one of our principles to obtain excellent predictable arthrodesis and stability of the SI joint. I continually shoot an image and save the image so that we can watch this compression occur. You can see very subtle turns as we do this. Once the implant shows evidence of turning, but there's no further compression or seating of the washer, then we stop. You can still see as we're doing this, though, some subtle compression. Once that's done, we put in our anti-rotation implant. There's a special jig that goes directly over the guide pin from your primary implant. And we go to the inlet view and place this typically through the middle hole, although depending on anatomy, you can go farther away or closer to the primary implant. On the inlet view, we should not be able to see this pin on the non-dysmorphic sacrum, as it's going to be placed directly below the primary implant, so that it will be hidden. Here we're aiming slightly too posterior, so I reorient to aim it slightly anterior. Now we're directly below it, so you can't see it. Now we're going to switch to the outlet view, and we advance this on oscillate to the level just lateral of the neural foramen of the corresponding sacral level, which is typically, in the non-dysmorphic sacrum, the S1 neural foramen. At this point, we are just lateral and cranial to the S1 foramen. This is the drill. We just poke through the outer cortex of the ilium. We keep the power going the entire time so as not to bind the pin and pull it out. Then I measure with the depth gauge and then place the appropriately sized anti-rotation implant, usually directly caudal to the primary implant. Once we are approximately 60 to 70% of the way in, I switch to hand power. We do not want the guide pin to advance, so I watch very closely to make sure that the guide wire does not advance over the screw. If it is advancing, just like it was here, I pull back on the guide pin slightly and re-advance the screw. These are the final images. This is the final outlet view. And then we will check the final inlet view. I don't cross the midline on unilateral cases because some patients do return for the other side, and we'd like to have good symmetry and the longest device possible. In my experience with patients that have unilateral SI joint disease, it does not always occur where the other side gets arthritic. At this point, we are injecting local anesthetic with a mixture of other medications to help with long-term pain control. It also can help facilitate an outpatient procedure in some patients. For closure, I typically use a 3-0 barbed suture with a deep layer that we ultimately sew back on itself in a subcuticular layer. We place a waterproof mesh-style dressing on top, which allows the patients to typically shower on postoperative day 2 or 3. In the typical primary setting, patients are weight-bearing as tolerated immediately after surgery, but utilize crutches or a walker for comfort only. Patients get their wounds checked at 3 weeks by their local provider, and then either return to see us in person at the 6 to 8 week postoperative mark or a virtual visit. At the 6 to 8 week postoperative mark, patients start an exercise program of 10 to 15 minutes per day and can advance their lifting restrictions to 20 to 30 pounds as able. By 6 months postoperatively, patients have no restrictions and can engage in regular activities without limitations. The primary side effects that I have seen in some of my patients is some gluteal irritation for the first several weeks as the gluteus musculature heals from the surgery. This is what a typical closed wound looks like with its mesh-style waterproof dressing closed with gauze and tegaderm. These are the patient's final images. Many patients such as this do notice very early pain relief. Thank you for your attention.